So with a missed abortion, again, the two most common severe complications are infection and disseminated intravascular coagulation. So again, we don't leave that missed fetal demise in the uterus for very long. Disseminated intravascular coagulation. Disseminated means it's spread out over the body. It's not localized. It spreads. And we're going to talk about the normal coagulation that should occur and if it goes awry and goes into DIC. So DIC occurs when coag mechanisms inappropriately are triggered. So think about it this way. Anytime there is a bleed, the body compensates with clotting. That's a normal process. Anytime the body compensates with clotting, it can potentially overcompensate. This would cause massive activation of the clotting cascade. So this could occur in a trauma patient, anybody that's bleeding a lot, this could occur in them. It especially can occur in a pregnant mom because she already has elevated coag factors that are supposed to protect her at the time of delivery. So sometimes her body gets triggered and it overcompensates and it just cannot stop itself. So it results in hemorrhage, thrombosis, and or multi-organ failure. So think about an event, and the body could locally coagulate with the event if she has any bleeding, and it could recover just fine. The other way, the other route it could take is in DIC, the processes of coagulation and then breaking down the fibrin lose control. The result goes into just a widespread bleeding all over mom's body. With that bleeding, the body says, okay, let's send out the troops, send out coagulation factors and stop the bleeding. So what happens is it sends out too many troops. Okay, you got to keep a reserve. It sends out too many troops. So it uses up the fibrinogen. I describe fibrin as the glue. Okay, think it is fibrous. So that's what clots a bleeding episode. If too much fibrin is loosed in the body, it uses it up. And then what happens is more bleeding ensues. So you can see this vicious circle that starts. More bleeding, you got more attempting to clot. You have fibrin split products now floating around. These are dissolved proteins or proteins dissolved from a clot. So it's breaking down the clot. You've got fibrinolysis going down here, breaking down the fibrinogen. And then now it leads to large amounts of fibrinogen being used. Then what happens is it leads to large amounts of fibrinogen being used, which also leads to fibrin being deposited along the vessel walls. So what does that do? Think of the fibrin as glue. So there's more fibrin that kind of clumps on top of each other and sticks, turns into a thrombosis, and it occludes small vessels that then lead to organs, small infarcts in organs, impaired circulatory perfusion, which leads to organ damage, ischemia, and acidosis. So now when we think about this, think about the main organs, the brain, the heart, the kidneys, the lungs, the liver. And it can include any vessels to any of these organs. And then we have organ failure, and it could ensue to multi-organ failure. So this is just a graphic of, again, what we talked about. There's an underlying disorder, some sort of a disorder that leads her to bleed. So the underlying disorder would be the missed AB in this case, and it leads to a trigger event for mom to bleed, and it can either direct itself to local coagulation and recovery. That would be the normal thing for the body to do, or it could go into this systemic activation of coagulation. So this is that overcompensation of the body. So we've got lots of fibrin formed. We've got fibrin depositing itself in vessels, and we have microvascular thrombosis and organ failure. Consumption of platelets and clotting factors, and more bleeding. Okay, and this is what happens with the blood cells. We've got different type. We've got red blood cells, white blood cells. We have coag factors, and then you can see the fibrin here. That is the glue that lays down. And so it can end up occluding the arteries to organs. Okay, when there is so much deterioration to the microcirculation, perfusion to organs worsens rapidly, and as a consequence, systemic shock also worsens extremely rapidly. So this is the sort of thing we jump on quickly. Sepsis, you're going to talk more about sepsis next semester. Sepsis is something else we have to jump on quickly, because sepsis can go into DIC too. This is where we have patients die when they're in DIC. So we want to either prevent it, or we want to jump on it quickly and correct it. Values. So what's going to happen with your labs here? Well, she's bleeding, so we're going to lose platelets. We're going to lose fibrinogen. We're going to lose clotting factors because they're being used up. And our red blood cells are going to be reduced because she's bleeding. So what's going to happen on the other end is the fibrin degradation products or proteins are going to be elevated. Her PT time, prothrombin time, is usually prolonged. And the PTT time is usually prolonged. So she's not clotting as fast. And then the D-dimer test is elevated, which it should be negative in people that there's not a problem, not this problem going on. But it becomes a high level in DIC, and it measures the proteins from the fibrin that are circulating. Okay, and here's some pictures with that you might see on the skin assessment of somebody who has internal bleeding going on. We have ecchymosis here, like bruising. They're patchy areas of redness. Petechiae are the small pinpoint dots, and then purpura are these smaller patchy areas. You see petechiae here on mom, or on the eyelid, rather, and petechiae could be anywhere on the body. Okay, epistaxis, she might have nosebleeds, hematuria, bleeding in the urine, and GI bleeding, venipuncture oozing. So if lab comes up to draw her blood, or if you draw her blood, you might have a hard time stopping the bleeding. You have to put lots of pressure on. So onset of DIC is life-threatening. It's an emergency. It's something we don't stand around and evaluate. We act on very quickly. So she's got to have an IV in, just like any bleeding patient would have to, a large bore IV, because we likely are going to be giving her blood products. And O2, most definitely, get the blood that is circulating, get as much oxygen concentrated in that blood as possible to get to her organs, and then correct the underlying cause. So correct the bleeding, correct the sepsis, correct the fetal demise. Well, the only way to correct a fetal demise is get it delivered, or DNC. So it reverses this pathology. It will reverse the DIC pathology, and the clotting will resolve. Treatment. We may give her anything from FFP, fresh frozen plasma, to replace those coag factors. We may give her platelets to restore low levels. Remember what your normal platelet count is. Okay, think about that. Cryoprecipitate, correct low levels of fibrinogen, and maintain circulating, excuse me, circulating volume. and replace RBCs. So she may have packed RBCs to transport oxygen to the body's cells. And she's going to be on her way to ICU because we don't handle patients like this on the floors. They need 1-to-1 or sometimes more than that until they get stabilized. And then her renal status is going to be closely monitored. We want to make sure that we don't get renal failure with that mom. All right. Now, next thing we're going to talk about is habitual abortions. These are also recurrent, these are also spontaneous abortions, but these are recurrent abortions of 3 or more. So we've got to figure out what's going on. There's some problem here that we may be able to address. So here's some reasons for habitual abortions. Sometimes moms have a septum in their uterus. It can be a septum that divides the uterus all the way down, or just slightly. Sometimes if it's a real minor, these are called bicornate uterus. Sometimes if it's a real minor septum, she can grow a pregnancy there. If it's a larger one, she can't. Incompetent cervix, this is painless dilation without contractions, that the cervix, for whatever reason, is just not able to stay closed. It opens on its own. It is incompetent. It's incompetent with keeping closed. That can cause these repeated habitual abortions. Now, if we find this out, that the reason for her aborting is her cervix can't stay closed, then the next pregnancy, they will go in and do a cerclage where they tie or they suture the cervix closed, so it can't open. So it supports it staying closed through the pregnancy. And then they take that suture out at about 37 weeks so that she can then go into labor. So insufficient secretion of progesterone can be another reason for aborting. If she doesn't have enough progesterone, that placenta cannot secure itself well enough in the myometrium to stay viable. Immunologic factors. Sometimes mom's body just sees the pregnancy as a foreign body and rids itself of it. Okay, discharge teaching. We're gonna have her watch and report any heavy or bright red bleeding, fresh bleeding. She should only have old bleeding after she goes home. And then she may continue to have some discharge for a couple of weeks and cramping. Remember I said the cramping with this can be very strong at first. That cramping can occur for a couple of weeks. No douching, no intercourse until the bleeding stops for the fear of infection. Antibiotics may be prescribed. Acknowledge her grief and the healing that needs to take place. These women are sometimes referred to for grief counseling. Sometimes they need that. Losing 3 or more pregnancies is tough, because it's like, what is going on with my body? What's wrong with me? Why is this happening? And sometimes I know somebody right now that had one pregnancy, first pregnancy, and it was a total viable pregnancy, no problems during the pregnancy, and she's had 2 miscarriages now. So that's really hard, really, really hard for both her and her husband. Support groups, clergy, professional counseling. Postpone conception attempts per provider's advice. Okay, we're just going to follow the provider's advice there. So that concludes our abortions, hemorrhage with abortions. Now we're going to talk about other hemorrhagic conditions. Ectopic pregnancy. An ectopic pregnancy is a tubal, well, actually, it's typically a tubal pregnancy. Most of them are in the tube, but it can happen anywhere outside the uterus. It's the primary cause of maternal mortality in the first trimester, primary cause of mom dying in the first trimester.